I'd like to request our President, Shafala Ma'am, to introduce the speaker, the experts for today's session, and the topic for today. Over to you.
Thanks. Thank you so much. Good morning, good afternoon, and good evening. At the outset, I will welcome you all for the 17th Asian Oceanian Child Neurology Congress to be held in New Delhi next year from 16th to 20th of September. So please block the dates. Today, we will be having Dr. Robin Whitney talking about tuberous sclerosis complex and epilepsy. And we have amazing experts and many case presentations. Can I have the CV slides, please, Asmita? So the speaker is Dr. Robin Whitney, who is a pediatric epileptologist and neurologist, Department of Pediatrics, Masters Children's Hospital, Canada. And she is a very accomplished professional, has a recipient of William Hawke Award for Excellence in Clinical Teaching and the Division of Neurology, and member of International Child Neurology Teaching Network Epilepsy Module, and also member of the Canadian League Against Epilepsy Fundraising Committee and the Tuberous Sclerosis Alliance Professional Advisory Board. Thank you, Dr. Robin. And we have a panel of very experienced experts. Dr. Charutha Joshi, we is professor in the Departments of Pediatrics and Neurology, and the Roy D. and Reagan S. Iltman Distinguished Chair in Pediatric Epilepsy at the UT Southwestern Medical Center, the US. And her areas of specialization are developmental and epileptic encephalopathies, surgical and non-surgical therapies, and recipient of Exceptional Women in Medicine Award from Castle Connolly, and elected member to the Board of Directors, Pediatric Epilepsy Research Consortium, and serves on the International Affairs Committee of the Child Neurology Society, and treasurer for the International Child Neurology Association. Thank you, Dr. Charutha. Professor Hassan needs no introduction, our friend from Turkey, who has been so actively participating, and many people from Turkey have been presenting cases. We are very grateful to you, Dr. Hassan. And then we have Dr. Suresh Pujar, who is consultant pediatric neurologist at the Great Ormond Street Hospital for Children, London, and an honorary lecturer of the University College of London, UK. And his areas of interest are status epilepticus, Fires, Rasmussens, and complex epilepsies, epilepsy surgeries, ketogenic diet. Thanks, Dr. Suresh, for joining. And we have a friend, Dr. Zaviria Alvi, assistant professor in pediatric neurology from Department of Pediatric Neurology in Children's Hospital, Lahore, Pakistan, and whose special focus in epilepsy, stroke, and neurogenetics. Thank you, Dr. Javiria. And for moderating the sessions would be our own alumnus, Dr. Prabjot Kaur, who is currently a consultant pediatric neurologist at Rainbow Children's Hospital, Bangalore. And her epilepsy areas of interest are epilepsy, neuroimmunology, and movement disorders and neuromuscle disorders. Prabjot, over to you.
Very good evening to everybody. I would request Dr. Whitney to kindly start screen sharing and start her talk. We look forward to your interesting talk today, Dr. Whitney.
This is a 60-second webinar in the series of webinars, and we're happy to say that more than 70 country attendees have attended so far. Dr. Robin.
Can you see my slides?
It's visible.
Yes, we can see it.
And it's not presenter view, right? You can't see the notes or anything below, just normal view. Okay. Thank you. Thank you for the warm introduction, and it's really an honor to present today. So I have two screens, so if I'm looking, it's just because I have a dual monitor. I'm going to be presenting on epilepsy and tuberous sclerosis complex today, which is one of my clinical and research interests. So to begin, relevant disclosures are that I've previously received some consulting fees from Jazz Pharmaceuticals. The objectives of today's presentation are to review the concept of mTORopathies, as well as the mTOR pathway. We'll review the presentation of epilepsy and TSC, understand the impact that epilepsy can have on individuals with TSC, and review some advancements in the treatment of epilepsy related to tuberous sclerosis complex. So to begin, as we all know, monogenic etiologies of epilepsy and developmental and epileptic encephalopathies are being increasingly recognized. Up to 50% of epilepsies may have an identifiable genetic cause, and there are a number of different disease mechanisms that are implicated in the genetic epilepsy, such as channelopathies, disorders of protein translation and modification, synaptic dysfunction, etc. And we know that dysregulation of the mechanistic target of rapamycin signaling pathway, mTOR, may cause epilepsy, as well as malformations of cortical development and neurodevelopmental disorders. And They are termed the enteropathies. This is a schematic figure showing the mTOR pathway, and enteropathies can be caused by pathogenic variants in genes encoding components of the mTOR pathway, and that's what causes the enteropathy. You can have a mutation either in the inhibitory components, so the components that generally prevent overactivation of the mTOR pathway, which include TSC1 or TSC2, or the Gator1 complex, which are associated with focal epilepsies, or you can have mutations in the activators of the mTOR pathway, such as REB, AKT, and mTOR. The phenotype is really quite broad and ranges from epilepsy alone to very complex multisystemic disorders. This is just a timeline of gene discovery in human epilepsies, and now there are over 900 genes that are associated with epilepsy. TSC2 was first cloned in 1993, and TSC1 was cloned in 1997. And you can see DPDC5 was cloned in around 2012, which is one of the genes in the Gator1 complex. So as I mentioned, enteropathies can really have a wide spectrum of disease, and you can have a mutation in either the inhibitory component of the mTOR pathway, so you have a loss of inhibition, or you can have a mutation in the activators of the mTOR pathway and have overexcitation of the mTOR pathway. And so some patients with enteropathies will actually have normal neuroimaging. Others will have focal cortical dysplasia type 2B, bottom of sulcus dysplasia, hippocampal sclerosis, band heterotopia, hemimegalencephaly, and megalencephaly have all been described. And as I mentioned, you can have isolated CNS involvement, but often there is concomitant autism spectrum disorder or intellectual disability as well. And this just highlights the spectrum that we can see with enteropathies. As I mentioned, sometimes you may have a normal MRI, other times you may just have focal cortical dysplasia, or it can be more complex, like with tuberous sclerosis complex, where patients will have multisystemic disease, subependymal nodules, the sagas, the cortical tubers as well. So this is just a diagram showing the different enteropathies that we can have. As I mentioned, you can have brain-only enteropathies or multisystemic enteropathies. So most commonly, the brain-only enteropathies include the Gator1 related epilepsies, which are secondary to mutations in DPDC5, NPRL2, or NPRL3. And Gator1 acts as an inhibitory component of the mTOR pathway. So when you have loss of function mutations in these genes, it causes overactivation of the mTOR pathway. With Gator1 variants, about 20 to 25% of the time, you will have abnormalities on neuroimaging, including focal cortical dysplasia, but the vast majority of patients actually have normal neuroimaging. And then you can have focal cortical dysplasia also caused by somatic mutations, so brain-only mutations in activators of the mTOR pathway, such as mTOR, AKT3, REB, etc. And the same thing with hemimegalencephaly. It's usually secondary to a brain-only somatic mutation in activators of the mTOR pathway. And then there's some very rare infantile developmental and epileptic encephalopathies, such as germline mutations in SZT2 and KPTN. And then there are a number of rare multisystemic enteropathies. The one that we will speak about today is tuberous sclerosis, which is the most common multisystemic enteropathy. So what is tuberous sclerosis? So hopefully you're all aware that TSC is an autosomal dominant condition, and it's one of the most common neurocutaneous disorders that we do see in pediatric neurology. And it's characterized by these benign and multiple hamartomas, which are benign growths. The incidence is approximately 1 in 6,000 to 1 in 10,000 live births, and the prevalence is about 1 in 20,000. In Canada, there are about 3,500 individuals affected by TSC. We know that mutations in TSC1 and TSC2, which code for harmatin and tuberin, account for about 80% of TSC cases. However, around 15 to 20% of cases actually have no mutation identified, and meaning you do blood work and you don't find a mutation in TSC1 or TSC2. Those cases are likely secondary to somatic mutations, so tissue-only mutations. 60 to 70% of mutations in TSC1 or TSC2 are de novo, and about a third are inherited. TSC2 generally has a more severe neurologic and systemic phenotype than TSC1 and no mutation identified. However, there are some variants within TSC2 that can be associated with a more mild and benign phenotype. As you all know, there are established diagnostic criteria for TS. You can make a diagnosis of TS with a confirmed genetic pathogenic mutation alone. Otherwise, definite criteria are 2 major or 1 major and 2 minor. And then a possible diagnosis is if you have 1 major or 2 or more minor features. So with regards to the mutations in TSC, they all are inactivating mutations or lead to loss of function of TSC1 and TSC2. As you know, TSC1 and TSC2 normally inhibit the mTOR pathways. So when you have a loss of function in an inhibitory component of the mTOR pathway, that leads to overactivation of the mTOR pathway. And this is what caused the uncontrolled cell growth and protein synthesis and benign growth that we see in TS. TS is 100% penetrant, but there is variable expressivity. And TSC1 typically is more common in families, whereas TSC2 is more commonly sporadic. So as I mentioned, all mutations within TSC1 or TSC2 are inactivating loss of function mutations. And these are germline mutations, which confer a risk for cortical malformation. However, you need a second somatic mutation plus the germline mutation in order to cause the abnormalities that we see on neuroimaging with TS. And this complete loss of function leads to overactivation of the mTOR pathway in this 2-hit hypothesis, with the germline TSC1 or TSC2 variant plus a second somatic hit have been shown in tuberous sclerosis complex. So what about epilepsy and TSC? So we know that epilepsy and TSC-associated neuropsychiatric disorders, aka TAND, are associated with really the greatest disease burden, and SEGAs are associated with the highest mortality. The neurological manifestations with TS generally begin early in life, and this is really a critical time of neurodevelopment. Approximately 90% of individuals with TSC will develop epilepsy, and we know that TAND and TSC are very closely and strongly related. 90% of patients with TSC will have neuropsychiatric disorders or TAND, and only 20% actually receive treatment for this. Intellectual disability is very common. About 50 to 60% of patients with TSC will have epilepsy. And we know that earlier onset epilepsy is associated with higher rates of intellectual disability, as well as autism spectrum disorder in patients with TSC. And autism spectrum is usually diagnosed earlier in TSC, as early as 9 months, and it affects about 25 to 50% of patients. And so, as I mentioned, epilepsy and TAND are closely related in TSC. So we know with tuberous sclerosis, 80% of the time you're going to have a mutation in TSC1 or TSC2, and these are loss of function mutations. And then normally TSC1 and TSC2 inhibit the mTOR pathway. So you have this overactivation of the pathway because of disinhibition. And this results in mTOR activation, which results in abnormal neurotransmission, abnormal connectivity, abnormal synaptogenesis, and disruption of dendritic spines. And all of these mechanisms are felt to play a role in the development of the epilepsy as well as the TAND. And the epilepsy is obviously closely related to the TAND as well. And as you all know, there are several spheres of the TAND, which are illustrated on this slide. So why does epilepsy happen in TSC? We know that the disrupted mTOR signaling pathway in tuberous sclerosis promotes the epileptogenesis, and that there's a decreased GABAergic inhibition and overactivation of the glutamatergic pathways. And the tubers are composed of these dysmorphic neurons and reactive astrocytes and giant cells, which are similar to balloon cells. And that there is immature GABA signaling within the tubers, which promotes this overexcitation, and that the dysmature and immature neurons propagate epileptic discharges. There's quite a bit of controversy in terms of where the seizures actually arise from in patients with TSC. Some studies have shown that the seizures themselves arise from the center of the tuber, and then they spread to the perituberal cortex and rim. Others have demonstrated that even after resection, epileptic activity is found in the peritubular cortex after tuberectomy. And so it may actually involve more complicated, widespread cortical and subcortical networks and abnormal connectivity between the tuber locations and different parts of the brain. As you can recall, this is just a table showing the amendments to the FCD classification, and that there are striking similarities between FCD type 2B as well as tubers. We know that tubers are composed of these dysmorphic neurons and reactive astrocytes and giant cells, which are very similar to the balloon cells that we see in FCD 2B, which also have the dysmorphic neurons. So how does epilepsy present in patients with TSC? Well, we know that the epilepsy can be, unfortunately, very difficult to manage, and that most patients are medically refractory. 2/3 to a quarter will have medically refractory epilepsy. And typically the onset of epilepsy is quite early. In fact, 80% of patients will actually have their first seizure before the age of 2, which we all know early development in early life is really a critical time. And infantile epileptic spasms syndrome affects about 50% of patients with TSC, and that infantile epileptic spasms is more common in patients who have TSC2 variants as opposed to TSC1 variants, and that medically refractory epilepsy is actually more common in TSC2 than TSC1 variants. Adult onset epilepsy is pretty rare to see in TSC, only about 10% will present later in life with seizures. So the vast majority are going to present in the first couple of years of life and are very difficult to treat. With regards to the seizure types that are most commonly seen, epileptic spasms, which can be in the form of infantile spasms, or epileptic spasms can also occur throughout the lifespan. Focal seizures are extremely common to see in TS, and I do caution that they can be very subtle in terms of their clinical manifestations.
तू काय खाणार आहे? दोन बिर्याणी? दोन बिर्याणी?
Sorry. We could see a number of other.
ठीक आहे. तू एवढंच खाणार आहे?
Asmita, please mute yourself.
So the most common seizure types are the epileptic spasms and focal seizures. And the focal seizures can be extremely common, and I'll just show you a study in a few minutes illustrating that. And then it's common to see other seizure types like generalized tonic-clonic, atonic, tonic seizures, atypical absence, etc. This was a nice small study done by Kate Reeney's group, looking at the accuracy of parental seizure detection in TSC. And it's an Australian study from 2022 published in Epilepsia. And they basically examined infants with TSC who underwent at least 1 hour of video EEG recording monthly until the age of 6 months. And then the patients had a video EEG every 6 to 8 weeks until 2 years. They only included infants who had at least 20 hours of video EEG in the first 2 years of life. And a total of 9 infants were enrolled, which you can see in table 1, equal mix of both TSC2 and TSC1 mutations. Most of them had, a high tuber burden with, greater than 10 tubers. And this table just shows all of the patients and the number of ASMs that they've tried, whether they've undergone epilepsy surgery. And then table 3 shows the total number of seizures that were captured throughout the video EEGs that they had in the first 2 years of life. You can see that there were, 2 outliers, patient 5 and 6, who had, a very high burden of seizures, over 200 focal seizures. During the study, 674 focal seizures were identified in 8 infants across 24 hours of video EEG. And that equated to about 1 seizure per hour. And the average length of recording was around 26 hours. They found that roughly 30% of the seizures that were captured out of the 674 were clinical seizures with very subtle features, including behavioral arrest, but the patient could still follow their parents. Other seizures, other clinical features included hyperkinetic movements, eye blinking and gagging in about 12% of patients. Over half of the seizures that were identified, the focal seizures, were subclinical seizures, so very high burden of subclinical seizures in infants with TSC, and less than 10% could not be classified. What was interesting was that only a third of the clinical seizures that were identified could be identified by parents, and the vast majority, 70%, were not actually recognized by caregivers. And so the study concluded that obviously seizure frequency is very high in TSC, especially in infants, and parents often miss clinical seizures. As mentioned, 70% of clinical seizures were actually missed by caregivers. And these seizures are often very subtle in nature and non-motor in their semiology. They also found that the recognition of epileptic spasms is poor, and despite parental education, recognition of seizures is difficult. And there may actually be a role for more kind of prolonged video EEG monitoring to evaluate for clinical seizures in patients with TSC, as well as subclinical seizures as well. So this leads to the question of who develops refractory epilepsy in tuberous sclerosis complex. We know that increased risk of medical refractory epilepsy is definitely associated with a history of infantile epileptic spasms. Typically, TSC2 variants are associated more commonly with medically refractory epilepsy. And we know that having a high number of cortical tubers and having a high tuber load is also associated with medically refractory epilepsy in TSC. A previous study also found that having a high tuber brain proportion was associated with earlier onset epilepsy, infantile spasms, and decreased effectiveness of anti-seizure medications. And having a high tuber load and volume is also associated with a more severe neurological phenotype overall. There are a number of other lesions, however, that can be seen in a tuberous sclerosis complex, which include these diffuse lesions as shown in D. And diffuse lesions are usually associated with medically refractory epilepsy, as well as early onset epilepsy and a poor response to anti-epileptic medications or anti-seizure medications. They're also associated with infantile spasms. And the wider the distribution of these diffuse lesions, the greater the association there is towards developing IS and refractory epilepsy. Patients can also have these cortical cyst-like lesions, which are also associated with early onset epilepsy, infantile spasms, and poor response to ASMs. They are more common in TSC2. And as I mentioned, the tuber load is generally more common in TSC2 as well. There are a number of other lesions that can be seen, these subcortical cyst-like lesions, as well as subependymal nodules and SEGAs. There is no real relationship between these subcortical cyst-like lesions, SENS and SEGAs, and medically refractory epilepsy. But we do know that having, a high tuber load, having these cyst-like tubers and diffuse lesions are associated with refractory epilepsy. So what is the impact of epilepsy in TSC? So as I mentioned before, epilepsy is associated with the presence of intellectual disability, as well as autism spectrum disorder and ADHD. We know that having early onset epilepsy in TSC is associated with severe intellectual disability, especially if the seizures start before the age of 2. And the presence of any seizure before 12 months, and in particular IS, is predictive of the development of global developmental delay in autism spectrum disorder. And we know that having seizure control and remission is associated with lower rates of intellectual disability. So earlier onset seizures are, associated with more severe neuropsychiatric manifestations, including intellectual disability and ASD in this population. We know that for infantile spasms, it's really important to treat these patients early, and that if we achieve control, there's higher chance of having a normal intellectual outcome. We also know that for focal seizures demonstrated here as controlling the focal seizures can be associated with better chance of having normal intellectual disability than having uncontrolled focal seizures. So the importance is that even having pharmacoresistant focal seizures can impair neurodevelopment. And we knew this for infantile spasms, but we know that having uncontrolled seizures can also negatively affect intellectual disability in patients with TSC. So this leads to the question of, can we intervene? And A here just demonstrates the mTOR pathway again. And this schemata figure in B shows the kind of progression that we see with the initial insult in TSC1 or TSC2, leading to hyperactivation of the mTOR pathway, abnormal connectivity, abnormal synaptogenesis. And then there's this latent period before we start to see epileptiform discharges on EEG. And then 2 to 4 months after you typically see EEG abnormalities is when seizures start to develop, and then seizures progress, and we develop medically refractory epilepsy in 2/3 of patients, and their seizures get worse, their TAN gets worse. And by that time, we're having to try several medications, the epilepsy surgery, ketogenic diet, BNF, which we'll talk about. So the question is, can we intervene between this, latent period where we see the EEG abnormalities and where seizures develop, or can we even intervene prior to the onset of EEG abnormalities? And we'll speak about that in a little bit more detail. You're probably all aware of both the EPISTOP trial, which is European trial, and the PREVENT trial, which was a prospective, multi-center randomized control trial that randomized infants under the age of 4 years to conventional treatment, waiting until they had seizures to start vigabatrin, or preventative vigabatrin when abnormalities on EEG were identified. It was, a small trial. 27 infants were randomized to the randomized control trial and 27 to the open label trial. They did find that with preventative prophylactic vigabatrin, this led to a lower median time to first seizures with preventative treatment with vigabatrin than with conventional treatment. They also found that infants who received preventative vigabatrin were more likely to remain seizure-free during their study period. And at 2 years, they were less likely to develop medically refractory epilepsy, infantile epileptic spasms with preventative vigabatrin treatment. However, the caveat to the study was that there was really no impact on developmental outcomes in these patients or rates of autism, possibly because, the small study numbers and, lack of longitudinal follow-up after 2 years of age. And then more recently, last year, the PREVENT trial, results of the PREVENT trial were also published, where, and this was a study from North America, US, where again, they randomized patients to either early vigabatrin or to placebo and delayed vigabatrin. Small numbers also, in this study. And the results of this study were different than the EPISTOP trials. So they found that early preventative vigabatrin treatment, when EEG abnormalities were present, delayed the onset in the overall prevalence of infantile spasms at 2 years, which is a similar finding to EPISTOP. However, as opposed to EPISTOP, they did not find a difference in the rates of drug-resistant or medically refractory epilepsy at 24 months. And it actually didn't lower the incidence or onset of focal seizures at 24 months either, which was in contrast to EPISTOP. And similar to EPISTOP, they found no improvement in neurocognitive outcomes or behavior at 20 months. 24 months, which may be related to the length of follow-up, the number of patients that were in the trial. But we have, 2 contrasting studies. The European study, which showed that preventative vigabatrin can delay the onset or prevent the development of infantile spasms, as well as medically refractory epilepsy and seizures, where the PREVENT trial only really showed that the vigabatrin can prevent infantile spasms from developing, but not medically refractory epilepsy. And neither trial showed, impacts on development or rates of autism. So, that leads to the question of what should we be doing clinically with these patients? We did a study a couple of years ago just in Canada looking at what are pediatric neurologists and epileptologists doing with regards to EEG surveillance in patients and infants with tuberous sclerosis complex. And we surveyed, 57 healthcare providers, and majority of them were physicians. EEG surveillance was done by about 60% of participants, and prophylactic ASMs were started in about 60% as well. Vigabatrin was most commonly prescribed, We didn't find a difference between having an access to a TSC clinic and not having an access to a TSC clinic and prescribing prophylactic vigabatrin. But as you can see, the duration of treatment was highly variable between different, 6 months, 6 to 12 months, or greater than 12 months. And no one was really following, standard clinical guideline. The international TSC surveillance and management guidelines don't actually recommend starting patients on vigabatrin preventatively, but they do recommend, doing surveillance EEG monitoring in the first 2 years of life. So what are treatments for TSC-related epilepsy? So generally, first, we start with anti-seizure medications as the first-line treatment. However, only about a third of patients will respond to anti-seizure medications. Typically, GABAergic medications are most often prescribed, and I find them to be quite effective in this group, and that may be related to the fact that GABA is decreased in these patients. Vigabatrin is obviously the first-line choice if a patient has infantile epileptic spasms, and 80% of patients with TSC will respond favorably to vigabatrin if they have IS. But vigabatrin also has a role outside of infancy. It can be particularly helpful in patients who have later onset epileptic spasms or who have tonic seizures and focal seizures. However, the caveat is that long-term use and high-dose vigabatrin can cause toxicity to the retina, so you just have to be mindful of that. Care also has to be taken with regards to the multisystemic nature of TSC, and that some of these patients also may have renal impairment if they have concomitant polycystic kidney disease with a contiguous PKD1 and TSC2 mutation. So we just need to be careful in terms of the ASMs that we're using. This is a nice a review article just looking at the different types of ASMs and the seizure and the seizure types and anti-seizure medications that can be tried. With regards to other treatments, epilepsy surgery should be considered really in all patients with TSC and refractory epilepsy. They should undergo an epilepsy surgery evaluation. We know that epilepsy surgery is really underutilized in patients with TSC, and there are a number of factors that contribute to this underutilization. These patients are complex. They often have multiple bilateral tubers. They have multiple different types of seizures. The seizures are coming from different areas. Investigations can be discordant, and the length of the pre-surgical workup is often quite long. There's also really a lack of consensus in terms of the best surgical approach in these patients, whether tuberectomy or the tuber plus the perituberal cortex should be taken out, lobectomy. And so that may also lead to physicians not working up patients for epilepsy surgery either. We know that 2/3 of patients with TSC may become seizure-free with epilepsy surgery. However, over time, this generally decreases to about 50%. There was one study that showed that early receptive epilepsy surgery may actually improve language functioning, expressive language and receptive functioning in children under the age of 2. There are a number of different techniques, as I've mentioned, that can be tried: receptive, like tuberectomies, lobectomies, multilobar resections. Hemispherectomy has been reported, rarely in the literature. This is usually reserved to catastrophic cases where it's the seizures are so bad, the patients are having lots of status epilepticus requiring ICU admissions, that something needs to be done. So not the norm, but is done in kind of emergency situations. And then of course there are palliative procedures such as corpus callosotomy, which can be helpful if there are atonic seizures or epileptic spasms. Corpus callosotomy may also help to better localize where seizures are coming from. There's quite a bit of work on vagal nerve stimulation and deep brain stimulation. There are a few reports of it being used in TS, but I presume that we will see more publications using this and have more information to guide treatment in our patients. So what are the factors associated with better surgical outcomes in patients with TSC? Well, if they have a single tuber and the seizure is coming from a single tuber, then that's really kind of the best case scenario for EEG and MRI all kind of line up. So we have unilateral EEG findings and MRI and EEG concordance. If they have an absence of generalized seizures, shorter seizure duration, if they're not delayed, and if you extensively resect the epileptogenic zone, that's usually associated with better seizure outcomes. If they have a focal tuber-like organization where the tuber behaves more like an FCD and the seizures are coming only from the tuber itself, these patients can have really, good outcomes, 80% seizure freedom. However, majority of tubers have this kind of complex organization where the tuber is linked to another tuber and to the surrounding cortex, where seizure freedom is not as great, approximately 40%. Other epilepsy treatments include, mTOR inhibitors. There's been a number of studies looking at the use of everolimus as well as sirolimus. Only everolimus is FDA approved for the treatment of epilepsy in patients with tuberous sclerosis over the age of 2. They have focal seizures. Approximately 40% of patients with TSC may have up to a 50% reduction in seizures with mTOR inhibitory therapy with everolimus. These, medications, however, do have a number of side effects, can be quite costly for families and need, extensive monitoring. The ketogenic diet can also be used in TSC, and the results of the diet are really kind of variable to date, ranging from 47 to 92% of patients on the diet have had at least a 50% reduction in seizure at 6 months, which again is really highly variable. And the long-term efficacy of the diet is really quite unclear. One study showed that the efficacy of the diet in TSC may actually decrease over time. So 50% response rate at six months in one study was around 58%, but decreased to around 30% at 2 years. It's unclear if the diet has effect on cognition or behavior or other TSC symptoms. And it's been proposed that, the diet may have some weak mTOR inhibitory properties as well. Really, we need longer term studies to address the efficacy of the diet, as well as different forms of the ketogenic diet, including classic, modified Atkins, LGIT in this population. As CBD or Epidiolex has been studied in the TSC population as well, with the GW Pharma study and then the open label extension study. The results were quite, promising, showing about a 50% reduction in seizures from baseline in both the 25 milligram per kilo group and the 50 milligram per kilo group, as opposed to placebo. The results with respect to seizure reduction were similar between these two groups, but the side effect profile was higher in the 50 milligram per kilo group. So we tend to prescribe 25 milligram per kilo per day. Most patients do well and have mild to moderate GI side effects like diarrhea and decreased appetite. The open label study also showed that over time at the 48-week range, that patients had sustained seizure reduction, and that the caregivers actually also saw an improvement in cognition and well-being as well. Epidiolex or CBD is FDA approved for TSC for children who have epilepsy over the age of 1 year. Typically, the max dose is 25 milligram per kilo per day. The RCTs did show, treatment effect regardless of whether the patient was also taking clobazam. We don't have, great studies examining the use of mixed extracts of cannabidiol with THC. Those are missing. And it's important to know that obviously Epidiolex CBD can have interactions with other anti-seizure medications, increasing the levels of clobazam. With valproic acid, we can see increased risk of hepatotoxicity and increased LFTs, as well as thrombocytopenia. And then really important for your patients who are on mTOR inhibitors, that CBD may increase the levels of mTOR inhibitors like everolimus. And so this can lead to toxicity, and you really need to monitor these levels quite closely in patients who are on concomitant CBD and mTOR inhibitor therapies. So what about the future of epilepsy treatments? Well, there are a number of clinical trials that are ongoing in the TSC population, and unfortunately don't have time to speak about them all today. But there is this TSC STEPS study, which is taking place in North America, looking at using early sirolimus in infants with TSC to see whether this may actually prevent the development of tuberous sclerosis, TSC-related epilepsy. And they're looking at quality of life and EEG biomarkers, as well as MRI biomarkers in this population. So this is obviously very exciting study, and we look forward to seeing the results of this. So to summarize, TSC is really the most common form of enteropathy that we see. Unfortunately, most patients with TSC will have epilepsy at some point in their life and present to a neurologist or epileptologist. Most of the time, they will present in the first 2 years. 80% have their presentation of epilepsy in the first 2 years, and 2/3 of patients have medically refractory epilepsy. As I noted to you, seizures are often really subtle and difficult to recognize. From that earlier video EEG study, 70% of parents were not able to recognize clinical seizures in TSC. And it's really important to highlight that epilepsy surgery may be a good option in refractory cases, and it's underutilized. So please consider epilepsy surgery evaluation in your patients. Thank you.
Thank you for the excellent talk, Dr. Whitney. I would now invite comments from my expert faculty. I would like Dr. Charuta Joshi to kindly give her expert comments.
Thank you. Thank you. I won't take too long. This was a fantastic overview, Dr. Whitney. Superb. It covered everything: genetics, early life epilepsy, epilepsy surgery. The only thing that I might like to point out is that, it is very easy because we had already, Sergiu Jozwiak had spoken all over the world about his EpiSTOP study. And that study really, the goal was, is preventive therapy better than conventional therapy? And in that study, the patients and the EEG ears, they were blinded to EEG results. But everybody knew that whatever they got was vigabatrin. So the vigabatrin treatment was not blinded. It was not a randomized study of vigabatrin versus something else. Whereas the critical difference is that in PREVENT, the study was about vigabatrin being randomized. So the study was whether vigabatrin is a good preventive medication. And since the primary outcome for the BEBIN study was developmental outcome at age 24 months, we know that from both studies, the developmental outcomes at 24 months were no different. So the fact that vigabatrin did not change focal seizure outcomes at 24 months is not surprising, because vigabatrin is not such a powerful medication for focal seizures, as we know. It perhaps works in about 40% compared to placebo. Now, it is a great drug for spasms, and PREVENT trial did show that, there is a delay in onset of spasms versus Jozwiak's study suggesting that spasms didn't happen at all. So there are some minor differences, obviously, as Dr. Whitney pointed out: power, numbers, short follow-up, perhaps. And in one of the studies, there were more TSC2 patients compared to the other. So that could have caused the differences. But sometimes, it's very easy to feel like the PREVENT study did not show us what EpiSTOP study showed, but really the designs were very different. The PREVENT study showed us still that preventive therapy is better than reactive therapy or conventional therapy, which is only when somebody has seizures you treat. But that if vigabatrin doesn't work, it's not the end of the world. We need to continue working. And that, again, Dr. Whitney pointed out that there is this upcoming sirolimus study, etc. So very, very well done. Thank you.
Thank you, Dr. Joshi. I would request our other expert faculty to also share their comments. Dr. Hassan, Dr. Suresh Pujar, Dr. Javedia.
This is Dr. Hassan Tetgul.
Hi, Dr. Hassan.
Thank you very much. Thank you, Dr. Whitney. It was really excellent overview on the tuberous sclerosis patient. Dr. Joshi also mentioned that anti-seizure medication plus some everolimus treatments also provide seizure outcome, but based on the neurodevelopmental outcome and autistic behavior disorder, we didn't get great success. Do you think we have different type of cognitive networks is different from the epileptic network, or autistic behavior network is different from the epileptic networks? Today we use currently we use EEG examination, EEG surveillance to follow up these patients. Do you think in the future we extensively use some functional neuroimaging studies to define the cognitive networks and autistic behavior networks and epileptic networks separately? Then my second question about is there any sequential therapy, vigabatrin plus everolimus or everolimus plus vigabatrin? Today we use a step-based approach to the treatment of seizure activity and then resolve the neurocognitive outcome. In the future, do you think we use the sequential therapy?
Thank you, Dr. Hassan, for your questions. I mean, I think it's a good, the first one about there being two different, networks. If we think about, developmental and epileptic encephalopathies, we know that, the single genetic change can cause developmental impairment, ASD, as well as epilepsy. And even if you remove the epilepsy, that these patients still have, the cognitive sequelae. So I think in TSC, there may be different mechanisms driving both the autism and intellectual disability, plus, the seizures. Definitely, having refractory epilepsy doesn't help from a developmental perspective. I think obviously we need, more trials and longer follow-up of these patients to be able to know for sure whether these prophylactic therapies actually have an impact on development or not, and are we giving them early enough in these patients' lives, or is it the horse already out of the gate kind of situation where it's already late and things are already established? With regards to the second question, with sequential therapy with vigabatrin and mTOR, I don't know if there's any clinical trials looking at that right now, but it's an interesting question. I always worry about what is the long-term effects of having these small children on mTOR over time as well. So I'm very curious to see what the results of these trials looking at prophylactic mTOR is, and whether it will have an effect on their development and epilepsy over time. Obviously, we need very long-term follow-up to be able to see this, and 2 years may be too short. My practice is that I haven't had the greatest success with mTOR use in TSC related epilepsy. It's also very hard to get in Canada for patients because we can't really get good approval for it unless they have insurance coverage. And I prefer to use other therapies in these patients. For patients that are being treated for AMLs and SEGAs, I just haven't found them to be as helpful as what the clinical trials have shown, but perhaps it's because these patients are older, the epilepsy is already established. So yeah.
Thank you. Thank you.
Dr. Javedi, Dr. Suresh, you
Thank you.
would want to
Thank you, Robin. That was very comprehensive.
Dr. Suresh, I think you're muted.
Can you hear me now?
Barely.
Can't hear me?
Yeah, the volume is quite low.
Okay.
Yeah,
well,
now it's good. Yeah.
Is it better?
Yeah, much better.
Okay, hi. Thank you, Robin. A very comprehensive overview. I agree with you. The everolimus kind of is a bit disappointing when you use it over the age of 2. And personally, I find it very difficult to maintain because of the side effects as well. And it's quite intensive kind of support they need for 50% seizure reduction in 40% of patients, which and again, in terms of it is meant to be more preventative. It makes more sense. So I always kind of felt that as an anti-epileptogenic agent, probably it would be more effective if you used it earlier rather than kind of waiting for epilepsy to develop and use it for drug-resistant epilepsies later. The other issue is if they are something to be mindful of is if they are also on ketogenic diet, both of them cause hyperlipidemia. And then in one patient, we had really big problem with the lipids through the roof. So just something to be mindful of. Just the other point on epilepsy surgery, as you rightly pointed out, it all comes down to patient selection. So if you have fewer tubers, good clinical EEG and tuber kind of correlation, then you get better results. In our practice, in our center, most of them kind of end up having stereo EEG before kind of picking and choosing which tubers are to be resected or whether they go on to have lobectomy. So yeah, those were just a couple of points I wanted to make.
Thank you, Doctor.
I agree with you. I think there was a question from Ranjith, who I know from this fellowship, about identifying the dominant tuber for epilepsy surgery. And I think it really obviously depends on your hypothesis and having a good hypothesis where seizures are coming from, good video EEG data, MRI, MEG, or ESI if you're able to get it. But the majority of these patients seem to be going for, stereo EEG now. And it's also about trying to, choose the most disabling seizure in these patients and knowing that it's highly unlikely that you're going to cure their epilepsy completely with epilepsy surgery, and that in some cases you may be buying, the child time in a critical time of neurodevelopment by stopping a very disabling seizure. But we obviously can't guarantee 100% seizure freedom with these patients, given their kind of complex networks. And then there's a very high, subclinical seizure burden in this population that obviously we can't chase subclinical seizures with, epilepsy surgery, and kind of have to accept that that's the case for these patients. We don't, know the impacts that these subclinical seizures can have either on these patients. So I think it, really comes down to having a good hypothesis and good pre-SEEG data when you're, working these patients up.
Thank you, Dr. Whitney. Dr. Javier, do you want to add anything?
So Dr. Whitney, it was an excellent and comprehensive talk covering all the neurological aspects of tuberous sclerosis. So yes, we know that 75% of these seizures become medically refractory. But fortunately here we see that 40 to 50% have refractory seizures, which ultimately gets better when we have introduced a ketogenic diet in these patients. Although we haven't correlated their genetic phenotype with either their TS2 or TS1, because we know that TS2 phenotypes are more severe as compared to TS1, but we haven't compared that. But our main issue here in our part of the world are the TAND, actually, the neuropsychiatric disorders, which becomes a bit of a more challenge than just managing their seizures. And just like the EpiStop trial that with preventative vigabatrin treatment, although it reduced the risk of seizures, but still these patients at 24 months of age had a higher incidence of autism, which we are seeing in our patients as well, which partly may be because of the disrupted neuronal networks that the tuberous sclerosis disease itself has, and then some of the environmental factors that also plays its role. So seizures here are there, and in some cases they have become medically refractory but have responded well to KD. But the TAND is also another issue which needs to be addressed as early as possible, just like you said that autism was detected as early as 9 months of age.
I agree. I think, the TAND is a really, really big issue for our patient population here as well. And unfortunately, there's, limited supports for these patients. There's long wait lists to see developmental pediatrician, long wait lists to see psychiatrists. It's really difficult to manage these symptoms, and they can obviously be more disabling than the epilepsy themselves. There was a trial looking at, using mTOR for improvement of TAND, and it didn't result in any definite improvement in TAND or their behaviors. So yeah, it's a real struggle in North America as well to manage these patients.
Thank you. There are quite a few questions for you, Dr. Whitney, and probably our experts can also join in. So quite a few questions about the use of vigabatrin. How early can we start vigabatrin? And if at all, for focal seizures, if we are starting focal electrical abnormalities, if we are starting vigabatrin, how long we can continue? And another question of, in case we are starting, we have a child who has responded well to vigabatrin with infantile spasms, how long can we continue it? Especially if there's a recurrence of spasms after stopping vigabatrin. So,
I think, okay, so how early can you start prophylactic vigabatrin is the first question. Is that the question? Yeah,
how,
so
do we start prophylactic vigabatrin is one question. And how early can we start it? How long can we continue it?
that's a good question. And I think, having the results of the prevention EpiStop trial have kind of, left confusion with some people in terms of what should we do with these cases. I do prophylactic EEG monitoring in my patients with TSC. So in the first year of life, every 6 to 8 weeks, they get a routine EEG with sleep. And then the second year of life, I do like every 3 months, they get an EEG. And if I see, multifocal abnormalities on EEG, or if there's definitely subclinical seizures, then I will offer prophylactic vigabatrin to the families. With the caveat that, there's been evidence that it can prevent the onset of infantile spasms, but not necessarily, medically refractory epilepsy or autism spectrum disorder. And I also counsel them about the risk of, retinal toxicity. Typically, I'll dose it between 100 to 150 milligram per kilo per day and continue it for 2 years because that's what they did in the trials, continue it for 2 years and then stop. There's really no evidence to continue it longer than that. We don't have evidence to show that longer vigabatrin treatment will prevent the onset of, late onset spasms or refractory epilepsy in this group. And so, yeah, I've started infants at like 1 or 2 months on it. Whether that's, the right thing to do, I'm sure everybody here does something different. And then, sorry, the second question was about
how long can we continue vigabatrin? I think that questions come.
I don't think there's yeah, it's like there's not a guideline in terms of how long. I would say from the studies, it's like up till 2 years. But the longer you're on it, the higher the risk of retinal toxicity there is, right? So I definitely have had some patients and families that want to continue vigabatrin because it's helpful for their focal seizures. But you have to have a conversation with family to understand that, the cumulative effects of higher dose of vigabatrin and the length of exposure is associated with retinal, toxicity. I'm curious to hear what other people do with the prophylactic vigabatrin. I know there's going to be a debate about this at AES in December, so I'm curious what the other experts do, if they provide it or not.
I mean, the practice is quite variable because of the uncertainty of the trials data. If both the trials had shown the same data, then it would have made things easier. And I think if we just focus on the cognitive outcomes, then it is kind of disappointing, even though the developmental outcome was looked at 2 years of age. So there is no consistent, at least to my knowledge in the UK, there is no consistent protocol that everyone follows. I think more often than not, people are not using preventative therapy as such. The other big concern is the tolerability. I mean, because they go on 150 per kilo, quite a few patients find it really difficult to tolerate that dose. And because of the neurodevelopmental difficulties they have, it's kind of almost impossible to assess the impact on visual fields, because you won't be able to do formal visual field assessment in these patients. So I think, yeah, I think there is some data to kind of support that, but I think there is still caution to be kind of exerted at this point.
So there's another question on how frequently have you seen kids with visual abnormalities or retinal toxicity when on vigabatrin? Like, there's a lot of concern, but have you actually seen kids coming with toxicity?
I haven't, because I always stop it before and don't keep kids on it long term. We used to do ERGs and sedate these kids, but we don't do it anymore. Because if they have infantile spasms, they're on it for 6 months and then I stop it. So I haven't actually experienced it before with the patients.
So I think that answers a question on what do you do for retinal assessment also. There's a question on what is the role of, is there any role of metformin in kids who have tuberous sclerosis? I think there are a few trials which were going on for metformin.
I've never used it. I'm aware of the trials, but I've never used it before.
Metformin is being tried for intractable epilepsy. Yes, I mean, when we had put one, but not specifically for TSC. I mean, and now regarding the preventive therapy, as Suresh was saying, even here we don't have protocols. Like some of them are doing, and many of them who are doing are in the corporate sector. Otherwise, because of the patient load and all, and not very clear guidelines, so many of us are not ending up doing. And yes, even we haven't seen a vigabatrin toxicity lately at all, because we also stop early. Yeah. Any other questions, Prabjot, then, so that we have to go to cases, please?
There are a lot of other questions, but ma'am, I think we can go to the cases.
You
And
want something on everolimus, you can ask. Something on everolimus, it was there, 2, 3, you can ask
there are a
that,
few
and then we
questions
can
on
go to the cases.
everolimus. A few of them
Yeah,
have
yeah.
already been answered. There's
Yeah.
one question about the management of everolimus related dyslipidemia. And in case there's one question, in case you have any experience with everolimus and hepatic vein thrombosis with coagulopathy, which is associated with TSC. I think somebody has a patient and they want to know your experience.
I have no experience with hepatic vein thrombosis and everolimus. And in terms of
Hyperlipidemia.
We have before. I don't know if anybody else has on the call. We do have a lipid clinic that we can send them to, but obviously it's concerning, especially if you're on a ketogenic diet as well. We don't know the long-term effects of these patients. I don't know if anybody has experience prescribing anything or just reducing the dose and seeing if it is effective.
Okay. I think
It has been amazing talk, Robin, as usual. And can we just go to the cases now very briefly, and then we'll have everybody, all the experts, and the main expert, you, as the comments, and in the end we'll just have take home messages. So I will just request, because there were 6 people, so we should do it between under 4 minutes each. Please don't go on the discussion. You just show the cases. That's it. Yeah.
So requesting everybody to finish within 4 minutes. If needed, I can give a reminder at around 3.5 minutes. So we will start. Yeah. So we will start with our first case for today. So I would request Dr. Ahmed Bilal to kindly start your screen sharing and start your presentation, please.
Is my screen visible?
Yes, your screen is visible and you're audible. Please start.
Assalamu alaikum and a very good morning, evening and afternoon. My name is Dr. Ahmed Bilal. First of all, I would like to extend my deepest regards to AOSCN and my mentor, Professor Dr. Tipu Sultan. Today, I'm going to show you the varied presentations of the tuberous sclerosis in the following 2 cases. My first case is about a 4-month-old girl who presented to us with the seizures started at 3rd month of life. She had an eventful birth events, and at 4 months, she had partial neck hold with the poor hand grip and eye-hand coordination. So this is the first video which is showing that she was having the left-sided clonic seizures at starting at 3rd month of life. So we continued with the examination of the child who was conscious with the normal growth parameters, with the normal neurological examination and systemic examination, but we thought that she was having these hypomelanotic macules on the back of the leg and the thigh. We continued to look for the similarities in the other family members, and we found out that her elder brother was at the 28 to 32 months at developmental age at 3.6 years of age. And he also had these kind of lesions on the leg and also on the forehead. And this baby girl was born to consanguineous parents, and there were 5 siblings, and already discussed about the elder brother and also elder sister who never got the medical attention, but also was having intellectual delay and hypomelanotic macules. This is the picture of her mother, who incidentally also was having these facial angiofibromas, but never had any other complications. And this is the EEG and the MRI of this index case. The EEG is showing the multifocal discharges, and the MRI is showing these white matter cortical hyperintensity, showing the cortical tubers. Also, the elder brother also had these subependymal nodules and cortical tubers, just fulfilling the criteria of tuberous sclerosis in both these siblings. So we started with the vigabatrin and the steroids, and we got a fair response to the seizure control. And also we continued for the systemic involvement, and no complications have been seen yet. Development assessment and therapy continued for both of these children. Now, continuing to my the second case, who was a 30-year-old girl, and her seizure onset was at the 6 months of age, and predominantly it was the myoclonic jerks, but she was also having the generalized clonic seizures, as you can see in the video. And at the end, you can see that she was also having these myoclonic infantile spasm of the extensor type. And also in the second video, which was taken later, she was still having these extensor spasms. So we continued with the history, and we found out that she was product of non-consanguineous marriage, and there were 4 siblings, and all the other siblings were quite healthy and with no neurological delays. And we continued to find out that she had a significant antenatal history at 35 weeks of gestation. She had an ultrasound done which showed the echogenic mass in the heart, and her skin examination again revealed these hypomelanotic macules. Her EEG showed these bursts of slow discharges, and also her MRI showed the subependymal nodules and the cortical tubers, again fulfilling the criteria of the tuberous sclerosis. And we at birth, since she had an echogenic mass on ultrasound, her echo was done, which showed large mass in the RV, right ventricle, and there was no inflow or outflow obstruction. So she was kept on follow-up since there was no signs of heart failure. From 6 months to 1 year, when she started having seizures, we started on the steroids and the vigabatrin, and we had only partial response. So at 2 years, when she's continued to have seizures and developmental delay, we started on benzodiazepines and ketogenic diet, and we got
Dr.
fair.
Dr. Bilal, requesting you to wind up.
2 years, and the seizures were well controlled. So just at the last slide, I would like to just briefly compare that in both of the cases. Both cases have hypomelanotic macules, but in the first case, they had focal seizures, while in the second case, she had infantile spasms. In first case, all the family members were involved. 3 family members were involved, but only 1 family member was involved in the case 2. So that is all from my side. This is my lovely family from the Pediatric Neurology Children's Hospital, Lahore. Now over to the experts.
Thank
Dr.
you for
Tipu, your comments. Prabjot, Dr. Tipu's comments mostly. Dr. Tipu? Dr. Bilal, Dr. Tipu is there? If he's not there, then Prabjot, you can take over to the experts.
Sure. Any comments from our experts for today for the present case?
Yeah, so Dr. Ahmed Bilal has concisely presented both the cases, and the main idea for presenting these 2 cases were that we had variable presentations, and we know that tuberous sclerosis presents with different manifestations at different points in time. And we talked about the cortical tuber load and correlating with the epilepsy burden. But the first family and the elder brother, although had a lot of cortical tubers, but did not have any seizures. So I think it behaves differently in different individuals. And the only purpose for showing that kid in this presentation was that although he had a lot of tubers, but did not have any seizures. So it varies from patient to patient.
Thank you, Dr. Javedia. So I would request Dr. Senem to kindly start her presentation after starting screen share. So we may be moving on to our second case. Yeah, your slides are visible.
Hi everyone, I'm Dr. Selma Aicha. I'm from Manisa, Turkey, and now I want to present a tuberous sclerosis complex, a case with drug-resistant epilepsy. My case is a 12 years old girl. She was born at term from healthy non-consanguineous parents in normal weight. She was diagnosed with cardiac rhabdomyoma in the antenatal period. Motor developmental milestones were acquired on time, and her family history was unremarkable. She had hypopigmented macules on her body and angiofibromas in her face, and also chagrin patch in her back and dental enamel pits. Her physical examination also revealed eye examination, multiple retinal hematomas, and her neurological examination was normal, but she had intellectual disability. In her cranial MRI, there were lots of cortical tubers and also subependymal nodules, and her echocardiography revealed a mass in the right ventricle, and also abdomen ultrasonography revealed multiple cysts. Her genetic examination revealed heterozygous mutation in TSC2 gene. She had atypical absent seizures when she was 8 months old, and multiple types of seizures have seen in this process, and multiple anti-seizure medication was tried. Here we see the epileptic spasm, and in this video, tonic seizures are seen, and here atypical absent seizures at first, and then myoclonic seizures, also gestural, bilateral gestural automatisms we can see here. And in this video, she had bilateral gestural automatisms, also left versive tonic seizures. And the EEG showed us multiple spikes, generalized multiple spikes, and then a suppression pattern. Also here are the similar we see. Her period medication was vigabatrin, but we couldn't continue due to the visual defects. Everolimus could not be continued due to the aphthostomatitis. Seizure control was achieved with ACTH treatment, but could not be continued due to the supply shortage. Also, topiramate and lamotrigine was tried, but it wasn't well controlled. And her current medication is valproate, clobazam, lacosamide, rufinamide, and also we practiced transaurical vagal nerve stimulation in this case, and she had a reduction of the seizures for about 50%. There is no still consensus on the optimal treatment in epilepsy in individuals with TSC. TSC-associated refractory seizures depends on the pathology in the mTOR pathway. Everolimus appears to be an effective treatment option with disease-modifying mechanism. And also, I want to share that transaurical VNS also could be an option for refractory epilepsy in TSC. Thank you very much.
Thank you, Dr. Senem. That was a wonderful case and very finished within time limit. Any comments? Dr. Pulat, is he online? Is he attending with us today, your moderator?
We are together with Dr. Muzaffer Polat, and the expert Hassan Tekgül. Senan, thank you very much for the nice presentation. Tuberous sclerosis patient with TSC2 variants, medical refractory epilepsy. I really enjoyed the video involving different type of seizure semiology and EEG surveillance. And so thank you very much for your nice presentation.
Thank you.
So I think we'll move on to our next cases. It will be presented by Dr. Deepti and Dr. Soma and moderated by Dr. Ranjit.
Is my screen visible?
Yes, your screen is visible.
Yes,
You just need to start the slideshow, that's all.
Sorry. Good evening, everyone. I'm Dr. Deepti, and along with Ms. Soma, we are going to present two cases from our institute of successful management of refractory epilepsy in tuberous sclerosis using two different approaches. The first approach is a combined medical and surgical approach. Our patient is a 12-year-old girl who's a known case of tuberous sclerosis on treatment from outside hospital. She presented to our center with multiple episodes of seizures with an onset in early infancy. Her main clinical seizures were myoclonic jerks and head drops, but sometimes even generalized tonic-clonic seizures, the frequency of seizures being daily. She was on conventional anti-seizure medications for the first 1 year of life, but in view of persistence of seizures, the family switched over to alternative medicine therapy. In this video, we can see she having myoclonic jerk. On her MRI brain, there were bilateral multiple cortical and subcortical tumors and a large subependymal giant cell astrocytoma with a dimension of 3.7 by 2.7 by 2.7 centimeters. It was a heterogeneous lobulated mass with an epicenter in left foramen of Monro with a mass effect and a midline shift to 7 millimeters to the right. Her EEG showed multifocal spike and wave discharges with a very poor background, suggestive of developmental epileptic encephalopathy. So a clinical diagnosis was tuberous sclerosis with developmental epileptic encephalopathy of a Lennox-Gastaut phenotype. On her MRI, there was a large sega with multiple bilateral tumors, but no specific dominant epileptogenic zone was localized. Thus, a resective surgery was not a feasible treatment option here. Hence, medical management of epilepsy and surgical management of sega was decided. Her baseline seizure burden was nearly 30 to 40 per day. After starting the anti-seizure medications, there was a partial response and the seizures reduced to 20 to 25 per day. Disease-modifying agent everolimus was further added, which improved the seizure burden to nearly 7 to 10 per day, but she was still getting daily seizures. Next, the sega surgery, excision surgery was performed using a neuronavigation guided parasagittal craniotomy with interhemispheric transcallosal approach, following which the child became seizure-free. In this post-op scan, we can see there is a significant improvement in the mass effect and there is no midline shift anymore. At 6 months post-op follow-up, the child was still seizure-free. There was an improvement in attention span and behavior. Since she was tolerating the drugs very well with no side effects, she was continued on everolimus, topiramate, and clobazam. She was started on rehabilitation, and the parents were quite happy and motivated to continue the allopathic system of medication. Before starting the therapy, the child was not able to sit without support, but now she is slowly gaining her milestones and she can sit with support.
I think there's only 1 minute left for the second case if you want to present.
Yeah, so I'll just go to the take-home message, which is an individualized tailored approach of combined medical and surgical intervention should be considered early in the disease course as they can lead to better overall outcome in terms of development, behavior, and epilepsy, and a management of sega can also contribute to epilepsy control. Thank you.
Now already done. So.
Now Ms. Soma will take over for the second case.
So Dr. Soma, I would request you to be quite quick with your case, please?
Yeah, definitely. Is my screen visible? Yeah.
Your screen is visible, you're audible. Please start.
So this is Soma. I'm a PhD research scholar from Sri Ramachandra Institute, doing my study under guidance of Dr. Ranjit Kumar Manokaran. So today I'm going to talk about ancient diet, modern impact, how an indigenous ketogenic diet plan transforms seizure management in tuberous sclerosis. So a 2-year-old boy was referred to us in view of multiple seizure in spite of multiple anti-seizure medication. He had multiple daily episodes of seizure, that is left side eye twitching and head nodding 6 to 7 episodes per day since 7 months of age, and was diagnosed with tuberous sclerosis type 1 pathogenic. Parents were doctors and have tried multiple anti-seizure medication, and hence was referred to us by their pediatric neurologist, Dr. Padma Balaji, to our center. This is the MRI brain. Here we can see multiple T2 flare hyperintensities in the bilateral cerebral hemisphere. This suggests tuberous sclerosis. This is the video EEG. Here we can see the child is playing, and suddenly he will be getting the seizure, that is mild uprolling of eye. So this was the video EEG. This is the video EEG at baseline, where we saw that there is 3 focal non-motor onset seizure with impaired awareness, with onset from the right frontocentral region, and 3 habitual seizure which are lateralized based on EEG to right hemisphere, and epileptogenic zone probably lies within the right frontocentral head region was captured. We proposed SEEG for further localizing the epileptogenic tumor. However, parents didn't want to proceed to SEEG at this stage in view of bilateral cortical tumors and young age of the child. Hence, we recommended ketogenic diet as a next treatment option. So a ketogenic diet was initiated, and demographic data showed that there was no family history of seizure, and the child belongs to a joint family and was developmental delay, and was the firstborn child of non-consanguineous marriage. Subjective data reveals that there is normal GI function. Objective data reveal that he was at mild risk of malnutrition. His biochemical data showed that he was having normal blood parameter. Clinical evaluation showed no overt signs and symptoms of nutritional deficiency. Diet history showed that the child was on mixed diet. This was the home diet at baseline. So he was taking, as he was from South Indian family, was taking idli, dosa, sambar, rice, and milk, and which is all carbohydrate rich. And so our aim was to achieve seizure control and reduce frequency and severity of seizure. So we initiated a non-fasting ketogenic diet based on non-fasting ketogenic diet protocol, which provided 6% of carbohydrate, 79% of fat, and 15% of protein. And once the patient reached 3+ urine ketone level, we initiated 2:1 ketogenic diet, which provided 10% of carbohydrate, 8% of protein, and 82% of fat, respectively. So it was based on nutritional care process model, where we did assessment, diagnosis, intervention, monitoring, and evaluation. So this was the diet plan which was provided to the child. This is an indigenized ketogenic diet plan, as he was belonging to South Indian family. So based on his cuisine, the diet was planned. And I'm doing my PhD, and as a part of my PhD, I have designed an indigenous ketogenic product. This is the product which we have incorporated in all the recipe, and we have given almond flour dosa, keto powder milkshake, and vegetable upma, and cauliflower rice, considering the child's cultural preferences. So as a result, the child became seizure-free on the 2nd day of ketogenic diet initiation, and his urine ketone level was also maintained at 4+ ketone throughout the day. The child is now in the 4th month of ketogenic diet with monthly follow-up session and remains seizure-free, constantly showing 4+ urine ketone throughout the day, and is tolerating the diet well. After the nutritional intervention, he started responding to his name and is more cooperative, playing and walking without support. And a nutritional assessment we did using
Investigate to kindly wind up, Dr. Soma.
yeah, a strong kids nutritional assessment tool, and he was now at low risk of malnutrition. So this is the video before starting the ketogenic diet. So he was not able to stand without support and used to get seizure daily 6 to 7 episodes. But now after starting the diet, this is the video 2 days back, he can now walk without support and is more active and playful. So the uniqueness about this case is, since the child belongs to a South Indian family, so we made a ketogenic diet plan considering his cultural preferences. And as we know that the South Indian cuisine is rich in carbohydrate, but ketogenic diet should be low in carb and high in fat. So considering his cultural preferences, we made an indigenized ketogenic plan, and where we have incorporated all the South Indian recipes like idli, dosa, biryani, so that it is effective and enjoyable for the child and manageable for the parents. The approach ensures that the diet align with both the ketogenic protocol and child cultural preferences. Thus, to conclude, I would like to say that this case underscores the potential of ketogenic diet as an effective intervention for TSC, particularly in patients with drug-resistant epilepsy. And ketogenic diet should be considered as a treatment option for patients with tuberous sclerosis. And ongoing support and education for families are critical component for successful implementation and adherence to the ketogenic diet. And further research is required to explain the long-term outcome of the patients on ketogenic diet with tuberous sclerosis. This is our team. Thank you.
So I think quick comments from your moderator, Dr. Ranjit.
Yeah.
What do you want to say?
Yeah. Thanks for the opportunity to present. So we found success with these 2 cases, although it depends on the underlying disease severity. I just want to ask the expert the first question which I asked, like, we know that SEGA doesn't directly lead to epileptogenesis, but however, the size and location we feel does influence the seizure pattern and the severity and the frequency and the drug resistance. Would like to hear about more on that. How does presence of SEGA modulate the epileptogenesis and even the intertuberal networks?
Mr. Robin?
Thanks, Ranjith. I definitely, agree in your case that it seems like the hydro didn't make the seizures worse. And obviously the patient got better when you treated, their hydrocephalus and put them on mTOR treatment. I don't know of any data to support, the location of the SEGA and its impact on epileptogenic networks, to answer your question. I know from, other studies looking at other TSC lesions that presence of, SEGA and SENS aren't supposed to influence the epilepsy phenotype, but certainly your case demonstrates that it does. I don't know if anybody else has other experience with that.
I mean, again, I'm not kind of aware of any data that kind of implicates SEGA directly with kind of within the epileptic networks. But I think the ones where you have big SEGAs and there is pressure effect, potentially that can have an impact on your seizure control. And yeah, I think in this case, it sounds like that is more likely to be the case rather than direct kind of influence on epileptic network. Because we have a lot of other patients with smaller SEGAs, and in those cases, even when you remove them, it doesn't have a significant impact on seizure outcomes.
Okay. So I hope Dr. Anjali.
Before we, I want to add one thing, not related to this, but for the case. One thing was in the second case, the child was reported to be seizure free on day 2. So I don't want this message to go, when you are trying the ketogenic diet, we have been doing various studies for last 16 years. So if you're in the study which we did, in which we had KD versus MAD versus the LGIT, the only three-limbed RCT which is currently published in JAMA Pediatrics. And in that, we found that, it at least takes 4 to 6 weeks for ketogenic diet and for MAD to show its response. But for LGIT, it takes 12 weeks. So I just don't want people to go with the message that it's something magical is going to happen. And actually, you have to try diet for 3 months before you say that it is not effective. And with, it takes 6 to 8 weeks for MAD and KD, but LGIT 3 months. So that was just one thing, because it must be other drugs and all which was going on, so it happened simultaneously. So the message should not go like that. Yeah, thanks. I know we are running, beyond time. Can we have the next 3 cases very briefly done? Very
Dr.
briefly.
Please start
Yeah.
your.
Hope my screen is visible and I'm audible.
Yeah, it's visible and
Yeah.
you're perfectly audible.
So in interest of time, I'll keep my history short. She is a known case of TSC, who's a 22.5-year-old female child with no specific handedness, who was handled by a pediatric neurologist till she got referred to us for her refractory epilepsy. So her seizure onset was day 15 of life, where she had right focal motor seizures with upper limb, lower limb tonic movements, later which her semiology evolved. At 6 months of age, she had a cry followed by sustained head drop, where the parents started noticing paucity of movement of the right side. There was multiple events in the same day, but it was not in clusters and brief, which clears our doubt, it being spasms. So the other semiologies were abnormal jerky eye movements and behavioral arrest, followed by paucity of movements on the right side. With these two semiologies, she presented to us. So with the clinical history, we could find her developmental quotient was 86%, which was really surprising with all her seizure burden and with TSC. Vigabatrin was tried in the early part of her seizure history, which stopped her head drop and right chronic seizures. Other seizures continued for a period of time, but again, all the seizures recurred. Everolimus was tried on her, which gave her severe reactions, so they had to withheld. And all other anti-seizure medications were also tried. So when she presented to us, we started her pre-surgical evaluation. In our first step, we did our video EEG, where the interictals is showing bilateral parasagittal paroxysmal fast activity, and there are independent left centroparietal spike and sharp waves, and also independent right occipital spikes. So in the 24 hours video EEG, with all her full medications on, she got 16 clinical seizures and 10 subclinical seizures. So the subclinical seizures were all had same onset, where it is left centroparietal region, and the clinical seizures, which is 3 seizure types which got recorded, which all were habitual. I'm not showing the videos in the interest of time. The seizure type 1 is epileptical nystagmus, where she has epileptic nystagmus towards the left, and the onset is very clear, which is from the right occipital region. And the second seizure type was she had a tonic seizure followed by negative motor on the right, where we can see that she is holding the phone on the left, and the origin is from the left centroparietal region. And this is the seizure type 3, which was quite was interesting, and it was doubtful also, where she had generalized tonic seizure, but followed by sustained eye deviation and head deviation along with the gyratory movement of the whole trunk version to the right. So here our thought process was the onset from the left, but in the EEG we can see there was generalized attenuation followed by fast activity more over the right frontal region. So then we started when we saw her MRI, where it is showing right occipital tuber and the left paracentral tuber, along with other multiple tubers, where we can see there is left frontal and also right frontal tubers. With this information in hand, we started forming our hypothesis. So where we can see the right occipital tuber is very concordant with her semiology and also the EEG, but the other seizure type where we had a little bit doubt, but that also with her proper clinical history, we could say all the subclinical seizures were from left centroparietal region, and the one EEG which I showed, that also could be from the same tuber, because it was very mesial in area which was parasagittal, which can easily get propagated to the right side. That also can explain the same tuber being the epileptic zone. So we thought whether the SCG can be implanted, but it's practically very impossible because of her size, because of her age, and also having multiple tubers in situ. So with all this rationale behind, we decided and we concluded that the ictal onset is from the right occipital and the left centroparietal. We went ahead with the simultaneous resection of these two tubers with all our echo guidance, ultrasound guidance, neuronavigation, and motor mapping. And then this is our outcome after 9 months post-op. She has no immediate or long-term deficits. She is seizure-free. 3 long OPD EEGs are showing no interictal IEDs and no subclinical seizures. Her speech improved dramatically, and the post-op neuropsychology assessment we are waiting, which will be done at 1 year post-op. Anyways, we know the TSC journey, and the parents have been very well informed. And thank you.
Thank you, Dr. Kavya, for that excellent case. Dr. Pragnya, your comments, please.
Thank you, Prabjot. Just wanted to show a case. This is a common dilemma in TSC, refractory epilepsy, multilesional, little kids. So what comes in handy? Does the semiology help you? Does the radiological features help you? I think Ranjit asked that question. How do you select a dominant tumor? This was a case where the MRI showed only type B tumors. There was nothing suggesting type B. There was no calcification. The size didn't lead us to any particular tumor. And I'm only talking about the frontal. The occipital data was pretty concordant. So what will help us? What can aid us in helping? So I thought this was a case where the clinical semiology really stood out. All the seizure types sort of lateralized very well to that left paracentral lobule tuber. So we sort of took a little bit of leap of faith, I suppose, and resected the tuber. And surprisingly, I think we've been proven right, at least with the localization of that tuber. So this was a case highlighting the difficulties in TSC, refractory epilepsy, and maybe in each case, the hope that one or the other modality might help us in taking a curative decision.
That was a very nice case, Dr. Pragnya. Thank you so much.
Thank
Over
you.
to Dr. Sandeep, sir, for the next case.
Comments from, or you want comments in the end? You can have comments in the end. We'll finish all the 3 cases, comments and take home messages once for all here.
Sure. So your slides are visible. Please.
Good evening, everyone, and thanks for this opportunity to present. And this is very close to me, tuberous sclerosis surgery, because this is very close topic of Dr. Kate Rainey and Dr. Simon Harvey, under which I studied my pediatric epilepsy. So just going forward, we have challenges about TSC. Like people here think that there is no epilepsy surgery for tuberous sclerosis. There is usually late referral. Obviously, financial burden is there, and families are also not convinced about epilepsy surgery. So we inaugurated TS OPD in November 2018, so 6 years ago, and we have completed 30 surgeries so far. So quickly going through this case, this is a 7-year, 8-month-old known case of tuberous sclerosis presented with a drug-resistant epilepsy. So she had some aura of feeling of tremors or some fear kind of feeling. And then she starts with a behavioral arrest, does not answer, gets silence and chewing automatisms, lasting for 10 minutes kind of, and frequency 2 per 15 days. And obviously she was tried on multiple anti-seizure medications. Birth history and developmental history was normal, but she started having learning disability since the seizure onset. So we had a clinical hypothesis that this is a focal seizure with impaired awareness. Probably we thought temporal because of the semiology, and we thought it could be a dominant temporal lobe. So this was the interictal EEG. Obviously, in a TS, you get a lot of activities because of multiple tubers. You have these are like a bilateral multifocal interictal discharges. But you can see there is a focality which is there, probably left frontotemporal. So there are good spikes and runs. Look at these left temporal runs. It's beautiful. So among these, if you see these EEG, like, you feel like it is generalized, or you also get GPFA. But within that, you'll have to find out where there is a focality. So she had beautiful left temporal and frontal focality. I'll just run this semiology to show you once. So here the seizure started. She is kind of staring not speaking. So very bland semiology. Probably you get this in a temporal lobe, and then she recovered after that. We'll skip through the semiology. And the EEG, what's showing temporal rhythm, but interestingly, it had good frontal buildup as well, F3. So this is the F3 electrode, which has a good buildup. And then actually the seizure started here and you have the temporal rhythm as well. And obviously it propagated and to bilaterally and more towards frontotemporal, left frontotemporal. So ultimately, the VDOG summary was predominant left frontotemporal, independent right temporal, bilateral and generalized spikes during sleeps, and ictal was left frontal or temporal, depending on how you take it. So look at this. These are the tubers. These are left frontal, left temporal, and there was one prominent right temporal as well. This was another tuber where you see this radiological what hypodensity, hypointensity within the T2 flare of the tuber, which we feel that it is quite epileptogenic. Psychology was good. MR rapid co-registration was done. So then at epilepsy surgery case conference, we thought probably we'll have to explore left frontal and left temporal. Obviously, people will think of doing stereo EEG in her, but then we thought maybe these tubers we can sample when we, because of we'll do the EEG and then we'll do the extensive electrocorticography. So we thought maybe one stage approach would be better for us. And then we did recording from frontal tubers, and this is from temporal tuber. You can see there is a good spikes at the temporal tuber. And then ultimately the surgical plan was to remove these both frontal and temporal tubers. We follow this like Simon Harvey philosophy where we just take out the tuber centers. We don't cut the surrounding tissue. Only the tuber centers are kind of a debulk, you know. So this was done. Obviously the post-op ECOG was good. But you're getting this kind of GPFA like activity. I think these things will take a time to settle down, but obviously the focal repetitive spikes were not there. This is post tuberectomy. Post epilepsy surgery, this was a 1 month EEG, but we have longer follow-up now. This was my like initial case, and almost 4 years now post epilepsy surgery. She is maintained on one anti-seizure medication. So I was just looking through our experience, and this is under publication, not yet published. So this was the old data with 1 year follow-up. So we looked at the intra-ictal discharges, ictal onset, and we and correlated that with the Engel outcome. So what we found, obviously, and everybody will agree with that, that unifocal seizures with localized ictal onset has the best post-operative outcome after 1 year of follow-up, and presence of spasms, multifocal intra-ictal epileptiform activity, diffuse onset of ictal rhythm has poor outcome. And I would like to conclude with that because of want of time. I haven't added anything else. The another thing, just a note I want to make it like you gave this preventive vigabatrin, and in 2 of my patients, I found it very useful. We do the serial EEG monitoring, and it actually prevented onset of spasms. Eventually, one child had a focal seizures, but then that maybe initial development period was taken care of. Thank you.
Thank you, Dr. Sandeep. I think we'll move on to our last case. Dr. Archa, can you start your case?
Yes, ma'am. Am I audible? Are my slides?
Yes, you're audible and your slides are visible.
Good evening, everyone. I'll be starting with my case. I'm Dr. Archa Bali, Junior Resident, MD Pediatrics, AIIMS Bathinda. So my case was a 6-year-old female who presented to us with acute abdominal pain and emergency. On examination, her vital vitals were normal. She was stable hemodynamically. On examination, she had tender abdomen, and on local per speculum examination, she had bulge in hymenal membrane and it was congested, blocking the vaginal opening. So bedside pelvic ultrasound was done in emergency itself, which revealed a cystic lesion and dependent debris in the retrovesical area and was suggestive of hematocolpos. So we did MRI pelvis to confirm it. On T2 images, this is the first image is sagittal section and it is showing displaced uterus anterosuperiorly because of gross enlargement of uterus and debris settled below and blood fluid level, which is suggestive of hematocolpos. And the second one is T2 axial image showing similar thing where blood fluid level is present and debris settled at the bottom, which was hence hematocolpos was confirmed. So emergency hemanotomy was done in emergency, and on post-op day 4, gynecology team noted the child had new onset neuropsychiatric symptoms, and pediatric neurology and psychiatric consult was sought for the same, and treatment charts and basic investigations which were already done were reviewed to rule out any drug-induced new onset neuropsychiatric manifestations, which was thus ruled out. So on further digging into history, there was a history of decline in academic performance, behavioral issues, irritability, frequent mood swings, which were present for the last 1 year and gradually increasing for the last year. There was also a history of seizures onset at 2 years of age, which lasted for 6 months and were controlled on anti-seizure medications. However, child did not currently have any seizure episode for last 2 years and was not on any anti-seizure medications. On anthropometric examination, height was 97th centile. For age, it was expected to be 115 centimeter, but the child was tall for age. 129 centimeter was her height. Weight was appropriate, and hand bone age was advanced by 3 years. It was 3 years more than the chronological age. Tanner stage for breast was 3, which would have been expected to be 2 at this age. On higher mental function examination, she was conscious, oriented to time, place, and person, and had an MMSE of 29. Cardiovascular, respiratory, and ophthalmologic examinations were normal. So these anthropometric and Tanner staging was suggestive of precocious puberty. On head-to-toe examination, she was found to have multiple gray-brown maculopapular lesions over face, which are on the malar area and extending into nasolabial folds. Which was also.
Can you do it faster? Can you just tell the positive finds rather than describing? Yeah, please. Yeah.
So on family history, there was no epilepsy history seen in family, and only mother had facial angiomas. On the back, she was also noted to have hyperpigmented macules, which are not so clear, so were examined under Woods lamp and showed fluorescence. So in view of neuropsychiatric manifestations which were worsening, history of epilepsy in past, features suggestive of precocious puberty and neurocutaneous markers, MRI was done. MRI brain showed these first 2 images are axial flare images, which are showing hyperintense radial bands extending from subcortical to lateral ventricles. And the third image is showing coronal section, T2 image, showing large arachnoid cyst extending from frontoparieto-temporal area. But there were no tubers in our case. EEG was done for new onset neuropsychiatric manifestations and history of epilepsy, which was normal. Ultrasound KUB was normal. For deducing central versus peripheral precocious puberty, we did hormonal tests, which post GnRH stimulation, LH levels were risen and hence were suggestive of central precocious puberty. So interesting findings in our case were 6-year-old girl who presented with acute abdomen and imperforate hymen, evaluated for new onset neuropsychiatric symptoms and ultimately diagnosed with tuberous sclerosis and central precocious puberty. In our index case, MRI brain findings showed white matter migration lines and subarachnoid and arachnoid cyst, but there were no tubers. So on reviewing literature, we found
I think just forget about the literature. Can you give the message, please? It's already, yeah, just no literature. No message.
It may have tuberous sclerosis may have atypical presentations also, in our index case, she presented with acute abdomen, and for neuropsychiatric manifestations and neurocutaneous markers, we worked her up, and ultimately she turned out to be tuberous sclerosis. So detailed history and examination is important. Thank you.
Thank you, Arvinder, your comments fast, please.
Madam, actually, in our case, epilepsy was not the prominent symptom, though it was controlled. The major thing was that the patient did not have any cortical tubers, which are considered one of the markers of epileptogenesis in tuberous sclerosis. There were no tubers, there was no sagas, and there were no nodules, only white matter radiating lines were there, and there were arachnoid cysts, which have been studied in detail in one paper, and they have proposed that in 5% cases they found in MRI of tuberous sclerosis, arachnoid cysts were present, and they have proposed it can be a part of the they have proposed that it can be a spectrum of the tuberous sclerosis complex. So our case, though the epilepsy was not a prominent feature, she presented with acute abdomen and features suggestive of precocious puberty, and hardly there is any literature which mention that what is the cause of central precocious puberty in tuberous sclerosis. So they have proposed that in a postmortem cases, there can maybe some hypothalamic tubers which are not visible on the MRI, which can be causing these features. So our case was tuberous sclerosis with central precocious puberty, and the MRI findings were little impressive that we didn't have any tuber, saga, subependymal nodules, only white matter radiation lines, which is a part of the major criteria, and arachnoid cyst.
Thanks, Arvinder. Thank you very much for a wonderful case, and thanks all the presenters for wonderful cases. Now I will request Robin and all the other experts to give any opinion on these last three cases and take home messages. Sorry that it has gone beyond 23 minutes, but everybody has been presented real well. But sorry we had to do it. That's why I requested everybody to do it 4 minutes. Yeah, Robin.
Yeah, I mean, just on that last case, we recently published a kid who had medically refractory epilepsy starting at the age of 10 or 11 with completely normal MRI and tuberous sclerosis. So it's definitely described and just important to keep in mind in any case of medically refractory epilepsy that, 90% of cases will have cortical tubers, 80% will have SENS, but you can have normal neuroimaging in patients with TSC. So it's just an important genetic consideration with these patients.
Anything else for the previous two cases, and your final take-home message for the attendees?
Yeah, I mean, I think obviously that was a nicely illustrated case of the epilepsy surgery in TSC. And I guess the take-home message would be that obviously TSC is a very heterogeneous condition. No patient with TSC is the same. There's obviously variable severities with regards to the phenotype and the epilepsy severity as well. We have a number of, fortunately, we have a number of treatments available to treat these patients, but it's about finding what the right combination of medications or surgery or ketogenic diet is for these kids. And it's really important to consider epilepsy surgery evaluation in these patients, because epilepsy surgery can obviously have a good impact on the seizures in these children. So highly recommend working these kids up. And I think we need to learn more about the role of prophylactic vigabatrin and potentially prophylactic mTOR inhibitors in these kids. So stay tuned.
Thank you. Thank you so much. Dr. Hassan?
Thank you, Dr. Shefali. Thank you, Dr. Robin. I really enjoyed this session. You provided a fantastic an overview. Then we watched nice 7 cases. I would like to take a message for the surgery cases. Today we do surgery for case lesion-based surgical treatment. However, tuberous sclerosis is an epileptic network disease, enteropathies. I believe in the future we are going to focus on the brain connectivity, and then all the surgical modalities will be focused on the brain connectivity, and then try to get best surgical results if we use the brain connectivity in the future.
Thank you. Thank you so much. Suresh?
The only thing I want to add to everything that has already been said is that if you have a neat hypothesis, it's not necessary to do stereo EEG like the case that Sandeep and Pradnya showed. There was very neat nice clinical radiology and EEG correlation. And in those cases, you should be able to do, even if you don't have the facility to do SEEG, for example, or it's not practical, then you should still be able to operate and come up with good seizure outcomes.
Thank you. Thank you so much, Dr. Javedi.
Yeah, so I'm just gonna keep a simple take-home message, especially for the pediatric neurology residents, that it's important to identify the electrographic seizures, which may be indicative of subtle ones before they go into the full-blown infantile spasms, so that we can initiate treatment early. And also, we need to implement a robust surveillance program for these TS patients, so that they can be intervened if there are any complications timely for better outcomes.
Thank you. Dr. Charuta, if you are available, I know you were busy, but you were online. In case you are available for any comment, last take-home message. Okay, it's probably not. Mahesh?
Nothing, madam. We had a nice talk and good cases.
Yeah, I want one message is there that one should also remember that, as it's very, very brilliantly Robin had showed, there is multi-system involvement, so one has to just keep that in mind, and also the TAN part. I think that has to be kept. The child has to be seen holistically. If one person is an epileptologist, but you are anyway a pediatric neurologist and a pediatrician at the base also, so you have to see the child holistically. That is really, really, really very important. And obviously, that will be kept in mind. And obviously, a pre-surgical evaluation will have to be done for all the drug refractory ones. And that is the only thing I want to say. And like we have had we had the webinars last 3 weeks, so we will be having a gap of 2 weeks for logistic reasons, and we come back on 6th with Dr. Derek Chang with a new session coming up. And I welcome you all for the Asian Oceanian Child Neurology Congress, and I would request Smita to show the video, and we have the registrations. Which thank you so much. Thank you. Thank you. Bye.
Thank you. Bye-bye.
Thank you. Bye. Thanks.